Welcome everybody to the next episode of The Doctor is In. My name is Dr. Mahmoud Traina. I'm the Vice Chair for the Heart and Vascular Institute at Cleveland Clinic Abu Dhabi. It's my pleasure to welcome Dr. Ronney Shantouf, a dear friend and colleague, and the Cath Lab Director at Cleveland Clinic Abu Dhabi. And today we're going to be talking about coronary artery disease and the treatments available. Welcome, Ronney.
Thank you very much. It's an honor to be here today, and I'm excited to have a nice conversation with you.
So I think we got a lot to talk about, and there's a lot of different angles we can cover in this. But I think it's just good to set the stage. So coronary artery disease or atherosclerosis or heart blockage gets talked a lot about in the general media, and heart attacks and all this stuff. Can you just give us a history or maybe a background of what does it actually mean and how do people develop it?
Coronary artery disease is a very interesting process. It's a process really where the arteries that supply blood to the heart start to form plaque inside of the arteries. And this is plaque that lines the walls of the arteries, and really they're wedged into the walls of the artery. Actually, all our arteries that supply blood to the heart have 3 layers to them. And this plaque actually develops between the first and the second layer. And if it's a mild amount of plaque, it doesn't cause any flow problems. It just means you have plaque. But if that plaque actually continues to grow to the point that it actually stops blood flow, that's when you start to feel it. And that's when a patient may have symptoms. They might start to feel different symptoms such as chest pain, short of breath. They might feel fatigue trying to exercise. They might get chest pain during stressful events. And these are a sign that plaque has gotten to the point that it is limited blood flow in the heart. The other big thing that can happen with plaque, and when we talk about coronary disease, and the thing that we worry about a lot, is if this plaque actually breaks open, then what happens is a lot of this substance that comes out of the plaque, it activates our bloodstream, and we actually start to form clot on top of the plaque. And that clotting process on top of the plaque is what happens when you're having a heart attack. And that's when somebody gets more of a sudden episode of chest pain or shortness of breath, or really feels an uncomfortable discomfort in this area. And that's when, if somebody comes to the emergency room, we do different tests. We see changes when we do an EKG. And that's, when they put the stickers on the chest to measure the electrical changes that may be happening. Or we find out with blood tests that some of the heart muscle itself has started to damage. And so coronary artery disease is really that whole spectrum. It's from the very, very beginnings of mild plaque or maybe changes in the really small arteries to kind of more extreme blockages that are, multiple blockages in many, many arteries. And what we do as cardiologists is we really manage that whole spectrum from the very, very beginning to that very, very end stage process.
Great. And I think we're going to probably try to later on focus more on kind of the late stage of the disease. But so somebody comes in with very significant and symptomatic blockage in their 60s. What do you tell them about when this process started? Because they always ask, when did this first happen?
Yeah, absolutely. So, I think a lot of patients feel the process, the first time they show up with the symptoms, they think that's when it really started. And we know from really decades and decades of research that the process started literally decades ago. So you're talking 10, 15, maybe 20 years before, slow and steady a process of building up of this plaque through time.
And so that's what we've learned. So the best treatment is starting a long time before with the prevention, and that's made a lot of strides in the last 40, 50 years from our knowledge of how to prevent the disease, both by lifestyle and diet and exercise, but also by medications as well.
Absolutely. And everybody that knows me knows I'm obsessed with the lifestyle issues and the things that are important. And that's really trying to help prevent the process from even starting in the first place. But it also helps to stabilize the process. So, having a healthy lifestyle with exercise and eating healthy, eating real food, exercising routinely, avoiding stressful situations. There's a lot of lifestyle aspects that we can get into, but that's really for another conversation, is fundamental to all of this. The other aspect is, of course, medications. We've learned through time and decades of research that are certain medications controlling cholesterol, for example, if patients have very high, what we call LDL, so you have a lot of these particles floating around, that helps to reduce the risk of having progression of the blockage or even reduce the risk of having a heart attack in and of itself. Maintaining good blood pressure, if you're a diabetic, being on the right medications, or how to prevent diabetes or how to reverse prediabetes, for example. But unfortunately, there is a group of patients that continue to progress, whether it's because they might be doing all the right things, but they have a certain genetic makeup or a certain just risk profile that inherently puts them at a higher risk, and they do still end up with more complicated blockages and conditions.
Great. And so now we're going to start focusing more on kind of that symptomatic portion, or when people come to us with the advanced stages of the disease. And, you know, back in the, not too long ago, maybe 50, 60 years ago, I mean, former President FDR of the United States had a heart attack and was treated with bed rest. So we didn't really have any therapies that we could really offer patients. Can you just give us maybe a brief history of how we started the development of this fascinating field of therapies and interventional procedures for coronary artery disease?
Yeah, so a lot of the original therapies, well, was basically nothing. It was just bed rest. And then slowly there are certain medications that we started to figure out, such as nitroglycerin, which is something nowadays you can either take as a medication or as a patch or even like a spray or a tablet under the tongue. They figured out this helps to dilate and relax the arteries and allow more blood flow. And so this is one of the first treatments that we even had, or even just pain control, things like morphine or things that were similar to morphine, medications that were similar to morphine. Other medications were discovered, beta blockers, different type of medications to help relax the heart, slow the heart down, statins, and multiple classes of medications for cholesterol lowering that help reduce the chance of it happening again or even preventing it. And then there was the advancement of catheters, where we figured out how to actually go in with a catheter, take pictures of the heart by giving
Actually
a little
done at
bit
Cleveland Clinic, the first one.
Cleveland Clinic, actually.
Mason Sones.
Yep, absolutely. Where the catheters were actually placed into the arteries for the first time, and they gave a dye and like a dense contrast material that you were able to see with live X-ray. And for the first time, we can actually see the blockages themselves in real time and start to think about what to do about it. And actually, some of the first treatments, apart from medications, was bypass surgery. I mean, this is really where things started, where we didn't have a way of opening up the blockages or relieving the blockage. So we actually, and there's a whole history behind that, but figured out how to bypass the whole thing, where we actually take a piece of a vein from a leg or use an artery from another area of the body. And just like if the highway or the freeway is blocked, you figure out a diversion to get the blood around in a different way. And this is really where things started. Actually, in the beginning, it was absolutely, no matter what you don't do, is you never put something inside of the arteries of the heart themselves. And we've obviously come a long way, where we've figured out that actually you can go in with a balloon, you can go in with wires, and you can start to open up these blockages and dilate and make room. And that was really the start of interventional or invasive cardiology.
So tell us a little bit about that. Okay, so back in the 60s and 70s, you had a heart attack, you had blockages, you got a bypass surgery. Everyone knows the triple bypass, quadruple bypass, 5-time bypass. So that became kind of, how did this whole field of interventional cardiology develop? And how has it progressed since the early days?
So, in the 70s is when we, some of the forefathers in the field, Grunzig, Dr. Grunzig was really the first person to go in and actually do an angioplasty in the coronary arteries themselves, and went in with a balloon and dilated an artery and proved that you can do it, and you can actually do it relatively safely. You can do it with an awake patient. And this started that whole field. And so from there, we went to what we call plain old angioplasty or balloon angioplasty, where you just go in with a balloon catheter and a wire and a balloon, and with that balloon, you inflate the balloon and you literally make space and you kind of squish the blockage up against the wall. And that allows for the blood flow. This was a huge success. However, through time, we learned that the arteries themselves can, what we call recoil, so they can re-narrow down. Or worse, they can actually tear open, and now you have an artery that has abnormal blood flow, and this increases your risk. And so that's where the studies and the research figured out the concept of stenting. So stenting was originally invented as a way to save the artery if it tore or if it re-narrowed after doing regular ballooning. And this was originally what we thought stenting was going to be. And that stenting is like a wire tubing that holds the artery open. And this allowed us now to take these balloon catheters, open up the arteries, and then put this stent in to keep that artery open. And that was a huge leap forward. And then we learned that those stents start to re-narrow themselves. And this is where medications got adjusted, and we figured out there are very specific medicines that we need to use after a stent goes in, medicines that keep the blood less sticky, and this allows it less chance that it clots. And that did really well at the beginning until we started to see that even despite the aggressiveness, the stents would re-narrow. The technology moved to adding a special drug on there to really help to make sure that the body doesn't form tissue around it. Now, other problems started to come up. We started to see blockages that were too severe or too dense. There was a lot of calcium, literally, like almost like bone-like material inside these blockages, and a regular balloon won't open it. It's not strong enough. It's too dangerous. It might tear. And this is where different tools started to get invented. So we have tools such as drills, where you have a drill that goes in, literally with a diamond tip at the front, and that really helps to drill open some of these. There's a laser technology, so a laser catheter, very specific type of catheter that will go in with a specific kind of light, and this will help to literally melt away or burn off the tissue or even break some of that calcified blockage open. We now have technology, so if we kind of fast forward to today, we now have technology where you use ultrasound. So the same way sometimes if there's stones that they do when they have when you have stones in the kidneys, they took that technology and now we put it into the arteries, and we can crack some of this calcium to help get the arteries open. Why are
not to cut you off, but like, okay, so now we've had all this growth in technology, a lot of available stents have become the penetration of interventional cardiology is everywhere in the world. I mean, now you go, there's basically no country in the world where these therapies are not available to some degree. At least in the major cities, you go to almost anywhere you can go to in the world, and you'll find people able to deliver these therapies, and many places across the world. What do you think differentiates the quality of work being done? I guess is a stent done in this place or that place or this city or that city? What makes certain places do it better than others?
This is actually the crux of how you...
Because it's available now. Everywhere can get it.
And there's a certain level of training to be able to just put product inside of the arteries and take it out. What differentiates quality is, do the physicians doing the work, do the nursing team that's part of the team, do they know, one, who is the right patient to even do a procedure on? Not all blockages need stents. Not all blockages need ballooning. And then two, if the right decision is to fix those arteries and fix it specifically with stenting, there's a technique. There's certain ways to put in the stents. There's certain methods to guarantee that stent will, I won't say guarantee, but have a higher chance of that stent staying open without having a complication. And this is where the quality comes in, is how do we, center A versus center B. Center A if they're going in to go in and do a procedure and just do it sort of quick and get it done, that's going to have a higher chance of a complication. That's going to have a higher chance of less success. There's going to be a higher chance that that stent doesn't stay open, for example, or worse, there's a complication that happens at the time. Versus, Institute B takes a more thorough approach and really does everything to reduce risk while trying to guarantee as much as possible to successfully open the arteries. None of these procedures are without risk. There's no medical procedure that we do that doesn't have some inherent risk. We're thankful, and specifically in cardiology, we have a lot of data to help us judge how risky something is. But in the end, there's always some small risk. And so this is what starts to differentiate quality. Do we understand what is the risk that we're taking on, and do we have a plan to how to keep that risk low as possible?
And as we've talked many times before, but you're like me, if you don't track it, you really don't know. So if you're not, the only way to know quality, because I'm sure you're like every other doctor I've ever met, you think you're really good at what you do. But if you don't track it and report it and see your rates and your complications, how well your patients are doing, and with clear objective data, you don't know. And I think that's very helpful. And I know as our head of our cath lab here, you really keep a very close eye on those numbers.
It's actually a point of pride, not just for me, for you, for our colleagues, Dr. Ashraf, Dr. Ahmad, but the cath lab themselves, the institute, the hospital, the country. I mean, we are lucky to track our data. We are lucky to be part of we are part of an international database. I mean, when it comes to our coronary work, we are part of something called the NCDR, which is American College of Cardiology database that tracks hospitals that are part of this process. So we are benchmarked against all the top hospitals in the world, specifically in the US in this particular database. And so we see exactly how we are doing. We follow the exact same metrics. We know exactly how we compare to other major institutions. We are thankful, and I think it comes to the testament of the teamwork that's done here, of being in some of the top categories when it comes to quality. And like you said, if we don't track it, we won't know if there's an area that we need to improve, if there's an area that needs to be worked on. So, I mean, I think that's one of the hallmarks of a great institution, is a place that actually tracks their work.
So now let me ask you, just before, actually I want to ask you about some of the complex stuff you do, but before we get into that, so in the common literature, common media, common layman's conversation, there's no more need for heart surgery. Everything is just a stent. Just if there's a blockage, just fix it with a stent, and there's really why go to open heart surgery? And like I always tell patients, nobody ever picked heart surgery, so nobody asks for open heart surgery if they can avoid it. But where has the field gone? So for our audience here, where do you think, what's the role for heart surgery for blocked arteries nowadays?
Well, I mean, I think the short answer is it's absolutely necessary in a lot of cases. The more complicated answer, the larger answer is it really depends on a particular case. But no, cardiology is incomplete without the option of heart surgery. And while nobody wants heart surgery, everyone always worries about heart surgery. There are plenty of times that that's actually a lower risk choice than taking the stenting route. Not just necessarily for the procedure itself, but for the long run. So what determines if somebody needs heart surgery? There's a few metrics that we do. It's important that we understand the patient themselves. Are they, for example, do they have diabetes? Who in general do better when we're with surgery than they do with stenting. How is the heart pump? Is the pump itself the heart? How is that working? What do the arteries actually look like? How complicated are they? Do we need to use all these fancy drills and things to break open the blockage? How many blockages there are? So actually, these are all the factors that go in, and these have all been studied, multiple research trials, thousands and thousands of patients to answer this one question. Is the patient better off with stenting, or are they better off with surgery? And again, going back to, we're very lucky here, is we take a very team-based approach. Essentially, all the patients that come into our hospital and a large number of the patients we see in clinic get reviewed as a team when it comes to this question. Literally, it's us sitting around a room with our surgeons, colleagues, our vascular surgeon colleagues, our heart surgeons, our expertise in the heart imaging, so the images that we do, and the primary, the cardiologists that are taking care of the patient. And we and we review these cases as a team to determine, as a team, what we think the best route is. And so, really, there's no option without heart surgery being an option.
And I think that's part of, I mean, that's part of what I love about the Cleveland Clinic Abu Dhabi. But in terms of the practice, the ability to really make team-based decisions on these, because they're never simple, and the key is each individual patient and each individual case has their own intricacy, challenges, both for surgical and for intervention, and really being collaborative in reaching that decision. Because in modern medicine, it's really not a one-man show or one-woman show. It's really takes a village, takes a team for patients to really achieve what is our ultimate goals, to really get the best care for that individual patient that's in front of you.
Absolutely, and we're blessed to have that ability here, and that's an extremely unique. It is not very common to have this kind of teamwork when it comes to patient care, where we can each weigh in on our expertise. I may have specific expertise in the arteries themselves and what would be the best approach. You're obviously going to bring expertise not just in that, but in the valves themselves, and what would be the best approach for the valve. It's the same question. Sometimes the doors, so we talk about the valves, sort of like the doors of the heart. What is the best approach for that? And I don't think you're getting a complete evaluation without getting a team-based evaluation for the majority of cases that we see.
Okay, Ronnie, so what do you do for the patient that you get, probably same like me, who the team has recommended bypass surgery and says, Doc, please can't you just put in a couple of stents and then we'll do surgery later if needed?
It really depends on the case. There are certain cases that really, really, really we'd be doing a disservice, and surgery is the way to go. And there are those cases where we will say we really can't be offering stenting or opening up the arteries from a catheter base. Then there are those cases that might sit in the middle, or we still think surgery is a better option. However, stenting is a possibility. It would be a higher risk, and that would be important that we let the patients know. It might be a higher complication. There might be a higher chance that they're going to have to come back and do surgery in the future. And in those cases, if that's the case we end up with, then it's really about pre-planning and approaching and giving the patient the best opportunity to have a successful, getting those arteries open successfully and keeping them open as long as possible.
Great. Now, next I want to talk to you about, now you're a co-director of our complex coronary program with Dr. Ashraf. So what does complex coronary mean? What are the kind of patients that get referred to you? What do you do with that? What is complex? Because coronary interventions are available everywhere.
So complex coronary, I mean, there are definitions that exist, and in general, these are, for example, patients who have multiple blockages in many arteries, a lot of calcium, a lot of bone-like material. They might have blockages in the main artery. They might have blockages at branch points, multiple branch points that increase the risk. They might have a complete blockage. It's literally completely blocked, and the blood vessels, these are called CTOs, or chronic total occlusions. The artery has figured out a way to send blood around, And you have to figure out how to open up the artery, and it may not be obvious where it is. And those are just examples. You might have a complicated patient, somebody with a really bad heart, barely pumping, and you have to figure out, how am I going to fix the arteries with the heart not pumping well? So that might be what we call high-risk interventions. And those are the cases that we will take very specifically and come up with a very specific plan on how to do it. This is where some of these tools are being used, and you have to be comfortable using them. You have to have used them a significant amount of time to know how to use them, because they are going to carry more risk. And a lot of these cases we actually do with more than one doctor together. So we'll do, for example, Dr. Ashraf and I will a lot of times do our cases together so that we give these patients the best opportunity. It's a teamwork, it's a team-based. We use both of our experience, both of our knowledge, both of our skill sets, and really apply it to the same patient to get the job done.
So this sounds like a lot of mechanical stuff, drills and lasers and heart pumps and a lot of tools that you need to get through it. And I think the same approach we can see in even when we talk about valve disease, really to be a complete and to really be able to treat everything, you got to have all the tools. And kind of, it's not just you have to have the tools, but you got to know which tool for which patient at which time to deliver and have the experience with those tools to be able to deliver the results.
Yeah, the more tools you have, the more risk, the more complications that are possible with these tools. And this is really where we start to talk about the teamwork, where we're ready to handle these situations. So not just having, let's say, 2 physicians in the case, but you have an excellent nursing team. You have an excellent surgical team that's there to back you up if there's any kind of situation. You have excellent anesthesiologists, vascular surgeons. This is, when we talk about a complex coronary program, this is what we're talking about. We're not talking about one doctor that may know how to do the procedure, but if they run into any kind of situation or trouble, there's nobody there to help them out and get them together, get the patient safely to the next stage. This is what's unique. This is what this program is about, that we do have here.
Yeah. And I think that sums it up. Modern medicine, complex medicine, really is teams of teams. So there's, you could bring the Grunzig back to life and the best interventionalist, but if he's not supported with other colleagues that can help do the work, he's not going to be able to take care of patients to that high quality that's needed. And that's why the need is really, it's not a one-man show, one-woman show anymore, like we talked about.
I mean, we've worked together on particular cases where they've had a complicated, very complex valve problem. So again, I like to use the house when we talk about a heart. So, you have the doors, there's a door problem, then there's a piping problem. And we figure out together as a team, well, how are we going to fix the door and fix the pipes? Which one are we going to do first? Are we going to do them together? Are we going to do the door first? Are we going to do the pipes first? This is where that teamwork comes into play. And I think that's one of the unique things that we have here.
And you need that expertise, right? So if everyone tries to do everything well in the modern era, it just really doesn't work well.
Yeah.
Great. Any closing remarks or anything you wanted to add?
I think this was a lot of fun. Hopefully, somewhat educational for folks out there, and we look forward to future sessions.
Great.
Chatting.
Well, thank you everyone for joining this episode of The Doc Is In, and looking forward to seeing you in future episodes. Take care.